So welcome everyone, and thank you for coming to Exercise Medicine Canada at Queen's University's public lecture. So we're very excited to welcome Dr. Blair to Kingston and to hear what he has to say. But before he begins, we just wanted to give you a brief background of our initiative. So I'm Andrea, one of the co-chairs of Exercises Medicine at Queen's. And just to briefly describe the background of our group, Exercises Medicine is an initiative launched by the American College of Sports Medicine, along with the American Medical Association. It was developed to encourage physicians to include exercise when designing treatment care plans for patients. More recently, the Canadian Society of Exercise Physiology, along with the Canadian College of Family Physicians, have adopted this initiative, and our group here at Queen's has become the first Canadian university to head the EIM on campus initiative in Canada. So right now, our group is primarily composed of graduate students in the School of Kinesiology and Health Studies, but we have plans to involve other faculties and disciplines in the future. So the mission of EIM at Queen's is really two-tiered. The first being to promote physical activity on campus as a viable way to prevent and treat illness and disease in the student population. And the second is to provide information and resources to involve healthcare practitioners in the prescription of exercise as a means of treatment and prevention. And this second point is really the ultimate goal of the initiative in the long term. So this semester, along with health counseling and disability services on campus, we initiated a pilot program to test the exercise prescription and referral form that we designed for use in student health services. We have 7 physicians signed on to be part of the pilot program, and right now they're using the resources that we developed, and we will be completing a mid and end of semester evaluation of the program to gain feedback from participating physicians. And hopefully we can use this feedback to revise it for its full implementation in the future. Along with the EPRF, we also developed a resource booklet as a guide to prescribing exercise for physicians. So we're very fortunate that the health counseling disabilities services on campus were so eager and enthusiastic in helping us put this initiative into action so quickly. And our next steps include, as I said, evaluating the pilot project and using that feedback to implement the EPRF campus-wide. Our long-term goals also include extending our resources to the community of Kingston. So if you're interested in our initiative or have any questions or concerns, please don't hesitate to contact us at our email, eim@queensu.ca, or you can check out our website as well, www.eimcqueens.com. So now I'll call forward Dr. Ross to introduce our speaker.
Okay, all right, thank you very much. Well, good evening, everyone. This is just a bunch of fun for me for 2 reasons. One, because a faculty member in the school, I'm just so proud of our graduate students and the work they're doing with the Exercises Medicine initiative. There's no money involved. There's very little credit involved other than the passion and the joy of doing this for themselves and the university. And I know I speak for our faculty when I say how proud we are. The second reason it's a bunch of fun for me is because it's very rare in the business, not that you get to introduce a senior colleague with international experience and with a number of credentials, but for me to introduce a friend. I consider myself very fortunate to be mentored by very few, but even people as young or old as myself, whichever way you want to look at it, we do look to senior people for advice, and I don't think there's a month that goes by where I don't call up Steve and ask for some advice on something, and there's never a time when he is not very pleased to give that advice. If I read all of Steve's credentials, it would be truly take me about 10 or 15 minutes. But just to give those of you who are coming from the public a sense of who's about to speak to you tonight, I will take some notes from an extensive biographical sketch, if I so desired. So right now, Dr. Blair is a professor in the Department of Exercise Science Epidemiology and Biostatistics at the Arnold School of Public Health at the University of South Carolina. He's a fellow of the American College of Epidemiology, Behavioral Science, American College of Sports Medicine, AHA, and about 4 other different associations. He's a past president of the American College of Sports Medicine, the National Coalition for Promoting Physical Activity, and the American Kinesiology Academy. He's a recipient of 3 honorary degrees, and I won't list the institutions in particular, but 2 of them are very prestigious institutions in the UK. He's received awards from many professional associations, including the Merit Award from the National Institutes of Health, the American College of Sports Medicine Honor Award, the Population Science Award from the American Heart Association, and is one of the few individuals outside of the U.S. Public Health Service to be awarded the Surgeon General's Medallion. He's delivered lectures to medical, scientific, and lay groups in 48 states and 50 countries, and I suspect that if Dr. Blair upgraded this, that number of countries would have risen substantially. His research focuses, as you will see tonight, on lifestyle and health, with a specific exercise, as you will see, of course, on exercise and his passion, physical activity. He's published more than 600 papers and book chapters in the scientific literature, and is one of the most cited exercise scientists, with over 36,000 citations to his body of work. And for those of you that don't know, that is an astronomical number. Something that our whole faculty put together can only dream about. So that's a reflection of what his peers think of his work. He was the senior scientific editor of the United States Surgeon General's Report on Physical Activity and Health. I've also been the guest of Dr. Blair's many times. And I also wanted to wanted to thank him for coming. I'd like you to go back, Steve, and thank Jane for letting you go and come up here. Jane is a lovely wife of many, many years as an academic in her own right, and someone that I care for very deeply. So would you all please take a moment and welcome Dr. Stephen Blair.
Well, thank you, Bob, for your 2 kind remarks. It is always a pleasure to work with you and colleagues and students. And I will take just a second, Andrea, to congratulate you and your fellow students on the Exercises Medicine Initiative. I've been involved in that program from the outset, and it really is beginning to take off. We're so happy that it's taking root here in Canada. In the last few years, I've gone to India, Turkey, China, Australia, I know some others, to talk about exercises medicine, and they've implemented it. And perhaps the most exciting thing was a little over a year ago, the Chinese Centers for Disease Promotion said exercise is medicine in China. Now, I think Canada is probably the same as the U.S. If your health minister or our Secretary of Human Services said exercise as medicine is something we're doing, you think the average doctor would even care? But I think in China, when the leadership says, we're going to do this, I'll bet they get something accomplished. And I know that you guys are going to get good accomplishments here at Queen's. So keep up the good work for exercise is medicine on campus and working with your local medical practitioners and so on. So here are my disclosures and the outline of the 3 topics that I intend to touch on fairly briefly here tonight. I think Bob told me that I only had 4 hours for this lecture, and but I'll try to keep it to that if I can. Now we'll start with non-communicable disease. I know some of you are health professionals, some of you are lay people, business people and the like, but I say everyone in the room, there's no one here who's surprised by this, that non-communicable disease, heart disease, cancer, diabetes, etc., are really the leading causes of morbidity and mortality, not only in North America, but really throughout the world. As you can see, 2/3 of all deaths. Now, there are tragic forms of death from murder and starvation and HIV, AIDS, and so forth, but 2/3 of all deaths are caused by non-communicable diseases. So this is the public health problem of the world. So I do have a question for you this evening, as you see on this slide, and I would appreciate your cooperation here. And I do not want you to just pander to me because you're polite to visitors, and you already know which one of these I'll vote for. But, vote your conscience and what you think. Which of these causes more deaths than any other item on the slide? So first, who votes for tobacco? Causing more deaths around the world. Yes, go ahead, get your hand up. Who votes for obesity? Thinks obesity causes more than any of the other items on the slide? There's some. Who says high blood pressure? Who says physical inactivity? Well, this is a kinesiology department, okay. Who says high blood glucose? Okay, most audiences I talk to, obesity gets up there at the top of maybe not the top, but near the top, certainly ahead of physical inactivity. And a reason for that is we are bombarded with the obesity epidemic. Oh my God, the worst thing that's ever happened to humankind. So I wanted to test out my biases a little bit. So yes, I need to do this again, but I'm sure it won't have changed very much. I go to Google and type this in. Oh yeah, well there's a lot of Google hits on inactivity and related items and eating too much. Look at that. Obesity, diet and obesity, inactivity, so forth. So we were actually a few of us writing a call to action for physicians to pay more attention to physical activity. And Dr. Liz Joy was leading the effort. I said, Liz, I did this search, and look at this. There's 30-fold more hits in Google for obesity than there is for inactivity. Let's put that in our piece. So we wrote 2 or 3 lines and said, this is the emphasis on obesity and inactivity, not getting enough. So as the academics here know, when you submit an article for publication, they send it out to reviewers to see is it garbage or might it actually be worth publishing. And one of the reviewers said, yeah, but that's Google. That's just, who cares about Google? What about PubMed? Even those of you not in the field can probably guess, well, that's kind of the official listing of publications in medicine. Said, what about PubMed? So Liz went to PubMed and found 40-fold more hits for obesity than for inactivity. So this is what is out there, not just for the public, but in the world of science, all this attention to obesity, and I'll come back to that a little bit later in the lecture. But I want to go next to some Lancet articles that were published just before the Olympic Games last year. And those of you, again, in the field know that the Lancet is one of the world's leading medical journals. And we were so pleased that they agreed to devote an entire issue to physical activity. And one of the papers in that series was led by Dr. Ai-Min Lee of Harvard. And in that paper, she and her colleagues were looking at, well, just how big is this problem of inactivity around the world? How many deaths or how many cases of non-communicable diseases and so forth. And the editors of Lancet and the authors themselves, they were very conservative at every step of the way, pulled together huge databases from all over the world to make estimates. And look at this, 6 to 10% of the non-communicable diseases due to inactivity. If we eliminate more than 5 million deaths a year in the world due to physical inactivity. And I know what some of you are thinking. See, oh my God, there's 7 billion people. What's 5 million prevented? Who cares? That's not very much. But maybe to put that in perspective a little bit, smoking causes 5 million. That's how bad inactivity is in terms of non-communicable disease and deaths around the world. So this is something I've been working on, obviously, for decades, and I'll show you some data from this large study that I've been working with for over 30 years. It's data that comes from a very thorough clinical examination at this clinic in Dallas. Each exam takes 3, 4, 5 hours. Each doctor in this clinic sees 3 patients a day, to give you an idea of how extensive and intensive and thorough the exam is. And unlike a lot of epidemiology studies where people rely on self-reports of various risk factors and so forth, here we have laboratory data. Of course, we do have a medical history, but again, each doc sees 3 patients a day. So this is not just a quick pass physical exam. Lots of clinical data from the lab, measure body composition, not just height and weight, body composition in the lab, and what I've spent a lot of time, CRF, cardiorespiratory fitness. All of these 80,000 patients have a maximal exercise test. Now, you can lie if I ask you about your exercise habits, or you could exaggerate. You can't lie to the treadmill. Put you on the treadmill, go to exhaustion. We get your fitness, and your fitness is determined primarily by your exercise habits in the weeks and months before the test. So we follow this group over time for people that got sick, people who lived, people who died, people who continued to live, and so forth. The first paper we published on fitness and mortality, now, gosh, 24 years ago next month. That's a long time ago. But here for men and for women, these are the death rates in the follow-up of, at this time, only 13,000 in the study. This is the low-fit group, again, measured by the treadmill test. Get out of the low-fit group, get in just into the next category, the moderately fit. And look at the death rate, 50% or more lower. Huge difference. You get out in the high fit group, maybe a little additional benefit. And to put this in perspective, well, what do you have to do to get out of the low fit? You have to do what the Canadian Physical Activity Guidelines recommend, 150 minutes of moderate intensity activity a week. 150 minutes in 10-minute bouts, and this is walking. Or if you want to do vigorous exercise like running, 75 minutes. We're not talking about training for the marathon. 150 minutes of walking. 3 10-minute walks a day, 5 days a week will get you out of this category and into this category. This is the bottom 20%. This is the next 40%. And although we call this high fit, it's not just a tiny handful of marathon runners. It's 40% of the population. Now, these people are probably getting 300 minutes of moderate activity, 150 minutes of vigorous activity. But again, it's not hours of exercise a day. But look at that. Now, those of you who may be in medicine, public health, I challenge you to find me other risk factors that show that big, that strong an association, or find me a drug that cuts the risk of dying in half. So when we published this paper in the Journal of the American Medical Association, immediately got criticized. So, well, yeah, but fitness is genetically determined. I mean, some people are fit and some aren't. So you're just looking at the influence of genes on mortality. So I said, well, I don't think that's true. In the first place, you can't name anything that we can measure in human beings that doesn't have a genetic component. Blood pressure, cholesterol, height and weight, and even some of you guys have genetic abnormalities out there, I notice. Some of us don't, right? So anything you can measure has a genetic component. But so the question would be, well, suppose you were low fit and you took up exercise and got out of that low fit category, would that make any difference? So a few years later, we had 10,000 men who had oh, wait a minute, this may have not been quite, I forget the number, who had 2 examinations in the clinic, so we could calculate their fitness at the first, second, and whether they were never fit, unfit at both, whether they were unfit initially, but they listened to the doctor, started exercising, and improved their fitness, or there were some who were always fit. And then we followed them after that second exam. They were all alive at the second exam. It is really hard to do exercise tests on dead bodies. So they were all alive at the second exam, and then we followed them to see who lived and who died. And I don't know, I forget how many died over the course of the follow-up. But here are the findings for cardiovascular disease deaths and for all-cause deaths. The never fit, these are the death rates per 10,000 man-years of observation. And what's 10,000 man-years? That's 10,000 men followed for 1 year, or one man followed for 10,000 years, or any combination in between. So you can see those who were never fit, who took up activity and became at least moderately fit, they cut the risk of dying in half, more than half for cardiovascular disease, not quite in half for all-cause mortality. So, and one thing I really liked about, I didn't put the slide in, this same pattern of results we saw in every age group, in those 20 to 39, 40 to 49, 50 to 59, and 60 and older. Same pattern. So even if you're 60 and older and you've been sedentary and unfit, it is not too late. If you take up activity, improve your fitness, you will get the benefit of reducing your risk of dying. So as we went forward, continuing to follow this population, and in 1992, the American Heart Association labeled physical inactivity as the fourth risk factor for heart disease, going with these three standard risk factors that have been around for some decades. So I began to think, well, I wonder how inactivity, low fitness, compares with these other risk factors. So in this slide, again, this study, this one was limited to men, as was the last one. And the reason for that, it's not that I'm biased against women. You'll notice in the first slide, 3,000 some women and 10,000 men. There are just a lot more men go to this clinic. And I wish we had 3 times the women that we have men, because you women are just lousy subjects for research like this. I'm sorry to have to tell you this, because the darn women won't die. And the men are really good at giving, if you want to study, Halloween is coming up, isn't it? And I suppose you dress up and go out and trick or treat. You want to dress up in a horrifying costume? Dress like an epidemiologist. We go around and count up dead bodies and see. But anyway, if you want to do mortality studies, you do have to have dead bodies. And again, death rates are lower in women. So sometimes, especially early on, we didn't have enough deaths in women to carry out the analyses. But anyway, back to the point. Low, moderate, high fitness in those with none of the traditional risk factors. The men with any one or any 2 or all 3. And all of these trends are statistically significant, showing the benefit of fitness. But take a look at this. The guys who smoked had high blood pressure, high cholesterol, but who were high fit, the death rate there is about 23 per 10,000. Compare that to the guys who had none of the other risk factors and were low fit, the death rate was 30. So you're more likely to survive if you smoke, have high blood pressure and high cholesterol, but are high fit, than if you're low fit and have none of those characteristics. That's how important it is. So just quickly look at some other health outcomes. We've published dozens and dozens, maybe hundreds of papers on the topic, and I won't bore you with too many. But for example, a few years ago, we looked at fitness and cancer and mortality of digestive system cancer. So a slide is presenting this data slightly differently. Again, here at the time of their exam, 100% of them were alive. As I said, it's hard to test dead people on the treadmill. And we now look at the die-away curves in the high fit and in the moderately fit. And you can easily see that the low fit ones died off at a faster rate. And again, this is significant. Now here, a study limited to women, breast cancer mortality, low, moderate, high fit, same pattern of results that I've been showing you. Get out of that low fit, get that 150 minutes a week, get out of the low fit category, greatly reduce the risk of dying of breast cancer. You get out in the high fit category here, it drops down even substantially more. What about non-fatal outcomes, like, for example, developing physician-diagnosed hypertension, as in this group of nearly 5,000 women. And again, the low fit ones, much more likely than the moderate fit. And a high fit, really, this is a 65% lower risk of developing blood pressure as compared to the low fit. And those of you interested in such things, and those of you who aren't, you just skip over this, but we do in these analyses statistically adjust for what we call confounders. Well, how about smoking? The smokers probably aren't as active and fit, and smoking might be causing hypertension. So we account for that in the statistical analyses. And these things never really make very much difference. It's the fitness that is powerful. Now, let's move on to what I used to call the prime of life. And I am going to have my colleague redo this study now because I have changed my definition of prime of life. As you might guess, it's now 70 and older. But when she published this a few years ago, men and women 60 and older, low, moderate, high fit, same pattern. Now look at the three age groups, 60 to 69, 70 and 80 and older. Even I begin to say, yeah, I'm not that far away from 80, but it sounds kind of old. So look at this. The 80 and older men and women who were high fit had a death rate about 1/2 that of the unfit men and women 2 or more decades younger. You getting the idea? This fitness is pretty powerful as a predictor of health outcomes, morbidity, and mortality. But I see a couple of people out there who are probably in the prime of life, as I am, 70 and older now, my definition. And you kids, you haven't come to grasp of this yet, but the death rate actually is 1. We all die. Someday, we all die. So some of us, and I say, we've come to grip, and we know that's going to happen, right? But there are things we fear worse than death. And if I had more time, I could go into preserving function, preserving physical function, being able to go shopping, play with your grandkids, go out to dinner, go dancing. So, or you could lose your function. You could be incarcerated in a home, and somebody could feed you, bathe you, and wipe your bottom. Anyone want to end up that way? No, thank you. Or worse still would be to lose function of this thing up here, and of course we call that dementia. Look at this. If you want to avoid having the doctor write a cause of death on your death certificate, that dementia was one of the causes of death, get out of the low fit category. You have 60% lower risk of having the doctor say, well, she died and it was a cancer that killed her, but she had dementia. It's one of the causes. So, boy, this is what some of us really want to avoid, right? Well, all of you should. And then an interesting paper published not too long ago, and one of my PhD students made these slides for me. The Grim Reaper. How fast can he walk? So this study, this was an analysis of community-dwelling men, 70 and older. They followed them for nearly 5 years, and they measured their walking speed. They didn't do a treadmill test like the data I've been talking about. Just how fast can you walk 6 meters? And so we get time, how many seconds or tenths of a second to walk 6 meters. And the fastest trials used for analysis. So how fast can the Grim Reaper walk? Well, the men who could walk 0.82 meters a second were 23% less likely to die during the follow-up. Death's preferred walking speed, and this is about 3 kilometers, was below this. Death, he really liked that. If you could only walk 3 kilometers an hour, death was going to get you. And what is death's maximum walking speed? Well, none of the guys, this is 5 kilometers, none of the guys who could walk 5 kilometers an hour over that 6 meter distance died. Not a single one of them. So, death can't walk 5 kilometers an hour. Just stay ahead of them. Let's look now at fitness and health outcomes in, I think I just have one slide, those with chronic disease. Here again, a group of men with physician-diagnosed hypertension. Now, they had that diagnosis at some time in the past. They came to the clinic for their examination, and at the clinic, of course, we measured their blood pressure. So, some of them who were hypertensive, their blood pressure was controlled in normal, so it's in normal ranges. Some of them, their blood pressure was still a bit elevated, and these are all people like those in this room. Well-educated, rich, like all of you. Well, students aren't rich, but, plenty of money. Of course, here, you get good medical care anyway. In the United States, if you're well-educated in the upper socioeconomic strata, you get good medical care, and all these people essentially were. But some of these guys, their blood pressure wasn't very well controlled, and some of them it was very poorly controlled. They were still in stage 2 hypertension. Now, some of the really alert ones in the room may know where I'm going next. Look at this. The guys with physician-diagnosed hypertension who were in stage 2, their blood pressure was still, it wasn't well controlled at all, but were high fit. That death rate, this is cardiovascular disease deaths, that death rate was 10 per 1,000 man-years. And these guys' blood pressure, doctor, you did a great job. You got his blood pressure under control. Good for you. But, oh, he's low fit. His death rate is 17 compared to the guy whose blood pressure isn't controlled, whose death, it was high fit, whose death rate is 10. So I'm not saying, don't get your blood pressure treated. Of course, if you have hypertension, it's good to be in this category. But some of you may be doctors, and if you are here, doctor, don't congratulate yourself too much unless you know, is your patient whose blood pressure is controlled, is he or she in this category or in this category? So exercise is a medicine. It's not the only medicine, but it is a medicine. And in addition to the cardiorespiratory fitness, which you get from aerobic activity, walking, swimming, running, cycling, playing sports and the like, there is another kind of fitness that we've been investigating in recent years. We've known for decades that muscular strength and power is important for athletic performance. It's only in the last relatively few years that we've had much data on measured muscular strength and health outcomes such as mortality. So here we published in the British Medical Journal 5 years ago now, I guess. Here are thirds of muscular strength, and again measured in the lab with a 1 repetition maximum bench press, 1 repetition maximum leg press, and sorted into thirds, weakest third, middle third, highest third, for all-cause mortality. Again, get out of that bottom group, and you cut your risk of dying by about a third. No difference between these groups for some reason. Cardiovascular disease, same pattern of results. I think I put in one more on strength. Cancer mortality, very familiar pattern that I've been showing you all evening. Get out of that bottom third of strength, get in this group, and you cut your risk, again, 35% of dying of cancer during the follow-up period, which was, nearly 20 years of follow-up. Now, of course, there are people who say, well, yes, but the epidemiology, you can't prove causation with observational studies. You have to do randomized trials. You have to do an experiment where you can control everything. And this observation you can't prove. So, as an epidemiologist, I've kind of resisted that notion. I also do randomized trials. And I'll show you a little bit of data in a moment. But okay, they've convinced me that we do need, for some things, we probably need some experiments to test. And Bob has a sign-up sheet that I'm here. I finally got funded to do a study, and he's going to, if you'd like to volunteer, he'll sign you up after the lecture. There has never been a randomized experiment of parachutes. So if you sign up for this study, we'll give you a parachute or something that looks and feels like a parachute. And then we will go up to 10,000 feet, and you'll jump out, and then we'll have some solid evidence. I think we know smoking causes lung cancer. We don't have to lock kids up in residential schools and force one set of schools to smoke and deny smoking. No, I think we can. But randomized trials are also useful. We did a very large, for a randomized trial, a large, tightly controlled exercise trial in postmenopausal women who were overweight or obese, who were mildly hypertensive. And I know there are a bunch of kinesiology students here. I have a target for you, and don't listen to Professor Ross on this. In this study, 464 of these women, randomly assigned, just like I see in the lab over here, come to the lab 3, 4, 5 days a week, exercise on the treadmill or cycle ergometer. And this was a 6-month trial, and we had a 97% adherence to the target of exercise that they were assigned to. So I like to throw that out to people like, beat that. Now, of course, as Bob knows, it wasn't Steve who did that, it was Tim who made it happen, Tim Church. But anyway, from this study, now just show you, I think, one slide about quality of life. And it brings up another point that is important. We've talked about death from different causes, talk about function, talk about dementia, but quality of life is something that, that's pretty important, isn't it? You stop to think about it. And you have a researcher here in Canada who's been one of the world leaders in studying exercise and quality of life in patients diagnosed with cancer. He and I were at a meeting in, Carrie Cornier, at a meeting in Munich a couple of years ago, and they had it was on exercise and cancer, and they had a press conference before, and they'd ask us to come to that. There was an old man who'd had prostate cancer and surgery, an old woman who'd had breast cancer and a mastectomy. And, of course, it was in German, so my friend had to whisper in my ear what was going on. But this woman was she was so excited. And Martin was saying she had a congenital hip defect. She'd been sedentary her entire life. She got breast cancer. She had the mastectomy. Her surgeon, who was Martin's partner in this, referred her to Martin's exercise program, cancer rehab program, and it changed her life. And you could tell by so excited. And I thought, I've heard Carrie's lectures and I know his papers, and here's a paper of ours on quality of life, but she really drove it home to me. It doesn't matter whether she lived a day longer or not. She's living so much better. And she's excited, and she could do things because she built up her fitness. So anyway, in our study in these postmenopausal women, and this gets at the same, the physical quality of life reports, the mental quality of life were all better across exercise. But one of the subscales is change in energy. And it gets at, do you feel energetic or not? Now in this study, these women, it was a dose response, so no exercise, or exercise at 50% of capacity in the lab for 72 minutes, no, not a day, a week, 136 and 192 minutes. And note that there's not really much difference. They're all different from the control. 72 minutes of just walking at half your capacity makes you feel a whole lot better. It gives you more energy. And I was talking with some of the students this afternoon. I'm becoming convinced, and I believed this for a long time, but the evidence is now mounting that everyone in the room probably has a sedentary job. It's those who are still working. You're sitting there pounding away at your computer. You sit there 2 or 3 hours. You get up and take a 5-minute walk. There is now evidence that shows you're more accurate when you get back and your mind works better. Take a break. Quality of life. Function better. Not only just in, you can now climb up the highest mountain, but just in daily activities, and you feel better and you feel more energetic. Move along here quickly. Another randomized trial one of my colleagues, Andrea Dunn, did. These were men and women diagnosed in a depression clinic by a psychiatrist, not just a questionnaire, that they had mild to moderate depressive disorder. She randomly assigned them to a placebo control where they came to the institute and did some light stretching, or she was trying to take the social interaction part out of it. You're depressed, you come in aerobics class, of course you feel better, your depression, because you're with friends. She had them exercise on a treadmill in a closet for 80 minutes a week or 180 minutes a week. And this group is a little more than the recommendations, but around 40% of them had remission of symptoms. And note, that's just what we see for drugs and psychological counseling. So again, exercise is not the only medicine, but it's a medicine that works for depression. So which is more important now, fitness or fatness? And I ranted a bit about the overemphasis on obesity. There's huge confusion. I mean, it should be pretty simple, an energy balance. You consume more than you burn, you're going to gain weight. You burn more than you consume, you're going to lose some weight, lose some fat. And I know, you physiologists, I know, it's very complex. Lots of mechanisms, lots of biological pathways. But at one level, it also is fairly simple. But there's huge confusion about this out there in the popular media, in the scientific journals, and I'm really getting sick of just the overemphasis on obesity and the ignoring of activity and fitness. And we're making bad public policy decisions, not making some good decisions. We pay far too much attention to diet and obesity than we do activity. Here's another Google search from last year. Type in Google, look at that. Sugar is worse for you than poison, look at that, compared to tobacco and so forth. If you type in heroin, cocaine, probably most anything else, and this is what we're bombarded with, that sugar is the cause of all evil, and too many people fall for that, even scientists. Well, let's go to Australia, for example. Over this period, the obesity rates tripled, sugar consumption went down. Same thing happened in the United Kingdom. Don't believe everything you hear in the press or on Dr. So-and-so's TV show. He's not a scientist. He's just trying to make money or trying to get you to buy his book and make royalties on his book. So we could have another test here. Here's this awful McDonald's meal. Look at that. This for a family of 4, Big Macs, and oh my God, fries and Coke and... When you could, and it would be much cheaper, note nearly $28, much cheaper to have a home-cooked meal. Baked chicken, some salad, baked potatoes, whole wheat bread, and have a glass of milk. Yeah. Which one of these meals has more calories per person, do you think? I mean, how many more calories in the McDonald's meal? How many vote for McDonald's? I know you're suspicious of me now. Well, look at that. 900 calories per person in that McDonald's meal and 37 grams of fat. That's awful. This is one meal, 900 calories. Think of that. Oh, gosh. And then, of course, you do see that the home-cooked meal had 34 more calories and 2 more grams of fat. Almost all. I was surprised when I saw this. Almost all of you are surprised at this, because you're bombarded with how awful fast foods and sugary drinks and so forth are. Now, fitness is good for you, thank God, even if you are fat. So, again, Tim published this paper now several years ago. These are men with physician-diagnosed type 2 diabetes. And if we sort them into the body mass index categories, normal weight, overweight, or obese, low, moderate, high fitness, low, moderate, high fitness. Now, there aren't a lot of obese guys who are high fit. There is, if you look around in this room, you can find at least one, I think. But here we combine the moderate and high fit. So look at the risk of dying of cardiovascular disease. If they're even just moderately fit, but are obese, compared to the normal weight guys with diabetes who are unfit, 2-3 times higher risk of dying. Now, believe me, you can probably guess why. I had my periodic medical exam just a few weeks ago. Every time I go to my doctor for my exam, I say, well, there's no need to weigh me. The nurse takes me, get on the scale. I say, well, no need to do it. Get on the scale. You cannot escape the doctor's office without getting your height and weight and body mass index calculated, at least in my experience. Can you escape the doctor's office without having your fitness tested? Yes. In this great medical center today, lots of people with type 2 diabetes. Did any of them get their fitness measured? I don't know. It wouldn't have been a lot. But look at the risk. It's the fitness that's important. Remember, they're all sick. And here again in what I used to call prime of life, the fit men and women 60 and older. And again, fit, that means they were just moderately or high fit. And this is percent fat measured in the lab, not just crude body mass index, percent fat measured in the lab. The death rate here, there's no difference in death rate between the fit ones, whether they're normal fat or fat. Same thing for the unfit. No difference in the difference is in the fitness. And I'm really getting tired of the world, the medical profession, ignoring this. and putting all the focus on fatness. And I know you say, well, yeah, but Blair, you may be an exception. I mean, how many fat people really are fit? You can't tell by looking whether somebody is fit or not, a good worker or not, a good parent or not, but we assign every negative characteristic to the fat person. Well, stop doing that. You're all biased. Everybody's biased against fat people, and I admit that I am too. But fortunately, you can always spot someone, maybe not in this room, but I can always find somebody fatter than I am. So, how did he let himself get in that kind of shape? You can't tell by looking whether someone is healthy or fit. So in fact, in these class 2 obese men and women, really quite fat, I'm not in class 2 obese, 45% of them were fit and proved it on a treadmill test. Now you look at men and women 60 and older who are normal weight, they're essentially all. So you can tell by looking at them, yeah, they're probably at least moderately fit. But there are plenty of fat people who are quite healthy, fit, etc. And there are some bad skinny people. Look at the next time there's a TV show and some terrorist, they're all skinny. I think they're doing this to attack fat people. That's why they're, I don't know. A lot of fat people in the buildings. Well, anyway. So, again, we're bombarded with how bad. Do you see in the papers here in the U.S., 2/3 of Americans are overweight or obese. It's probably close to the same in Canada. Well, why lump overweight and obese? First of all, obese isn't really bad if you're active and fit, but overweight is actually good for you. These are based on big representative national studies, our National Health and Nutrition Examination Survey, and the reference category here is the normal weight by BMI standards. And as Catherine Flegel showed a few years ago, there were 86,000 fewer deaths in the United States in the overweight category than would be predicted in comparison to the normal weight. In Class 1 obese, well, 30,000 more, but not statistically significant. And if you get up into Class 2 obese, then those overweight is good for, and there's plenty of evidence out there. Lower death rates in overweight groups. We've been sold this overweight nonsense. It's a political issue, but it doesn't hold up under good scientific investigation. Overweight is actually good for you if mortality. Now, it's not so good for you, and especially I look here at you young people, and especially, I'm sorry to say, you young women. It's not so good for you if you're looking for a date for the prom. That is, it does interfere there. Maybe even for an old person looking for a date or a spouse or what have you. So, if you lose weight, again, you go to the doctor, and if you're overweight even a little bit, you need to lose weight. And if you're obese, oh my God, you need to lose weight. So we did this study published a couple of years ago. All of these men had at least 2 examinations. Some of them had 25 examinations over many, many years. The average number of exams was, I think, 4.5. So we were able to model their changes in body weight, body composition, and fitness, and see if that predicted mortality. So over 900 deaths during this almost 12-year follow-up. And here these are fifths of change in these 3 variables. So the bottom 20%, the next 20%, and so forth. Body weight, the white line, percent body fat, is no difference. These guys were, I think, 45 on average at the start of the study. Whether they gained weight, gained fat, lost fat, stayed the same, it made no difference to mortality. And there's other research out there that will support that. On the other hand, if they improved their fitness, the risk of dying went down. I hope you're getting the message. Fitness is much more important than fatness. Now, don't get your hopes up. This is only a summary of the first 20% of the talk. But epidemiologists do like to calculate a thing we call attributable fraction. And as you can see, it's an estimate of the percentage of deaths in a population that we can say is attributable to a particular characteristic. So here in these 50-some thousand men and women, low fitness, obesity, etc., you can all read. I'm sorry, this is percentage of deaths due to these characteristics. And all of these percentages are adjusted statistically for age, for examination year, and for each other item in this table, trying to isolate on each particular risk factor. So you can see low fitness by these calculations caused 16 to 17% of the deaths. Obesity caused 2 or 3% of the deaths. And in fact, Karim Khan, University of British Columbia, when he saw this, I saw him present this slide in a talk, he said low fitness is more hazardous in the population than smoke-a-diabesity. Because if you add up these percentages for obesity, smoking, and diabetes, it's still not this high. Low fitness is bad for you. So, okay, low fitness is bad. You need to be active. Improve your fitness. So how do we get people to be physically active? We have now good consensus around the world. These are the World Health Organization recommendations. About 2010, I guess, is when the Canadian recommendations came out. Bob, is that somewhere about there? U.S. recommendations. There's great consistency around the world for kids, 60 minutes a day, adults, again, the 150 minutes I've been mentioning. There's good agreement on this. So if we got, well, if you believe IMN's paper that I mentioned back at the start, if we got everybody in the world to do this, there'd be 5.3 fewer deaths a year in the world. So even if you can't get the 150 minutes, do something. Avoid inactivity. Don't sit so much. Even, again, in our study with the postmenopausal women, doing half the 150 gets you a lot of benefits, both in terms of fitness and quality of life and so forth. And also the muscle strengthening. Our recommendations, the Canadian recommendations, 2 days a week of muscle strengthening exercises, focusing on the major muscle groups, upper, lower extremity, and the body core. But how do we get people to be active? You know, everybody, essentially everybody, according to surveys, knows that inactivity is bad for you, so why aren't they more active? Well, we have to bring social science, behavioral science into this, and I've worked with some of the best behavioral scientists in the physical activity arena. We need to bring in the theoretical foundations, various methods. Don't have time to go in to great detail tonight, but behavioral science is a science, and it's important. Last year, we published in the U.S., our National Academy of Sciences, Science Education in the United States. I think it was about a 700-page document. So I downloaded the PDF, I went to the find box, and I typed in behavioral science. Term not found. I typed physical activity, terms not found. Now, I am not opposed to physiology, to biology, to chemistry. Who's the biochemist? Is that you? Yeah. I'm not opposed to, but isn't behavioral science, shouldn't in our educational systems, and I'll bet you're as bad at it as we are, shouldn't we be teaching kids from the first day in school how to manage their own behavior so that they can lead healthy lifestyles or balance their checkbook or whatever, whether it's flossing your teeth, being... So we need to use behavioral science to do this. Now, very quickly, the model that my colleagues, particularly Professor Bess Marcus, has used is called motivational readiness. So even if you're not a behavioral scientist, if you're out here in pre-contemplation, you never even thought about it. I've never even thought of quitting smoking. I wonder. Never thought about it. Well, I thought about it, but, you know, I'm not, etc. And then you can prepare, you can get started, you could buy your walking shoes, and then when you're meeting the recommendations, you're in action, and if you keep that up for longer than 6 months, then you're in maintenance. So this is the model we try to use to help people adopt, in our case, physical activity behaviors. So Professor Marcus has developed questionnaires to assess where people are, and of course what people want to do is go from pre-con to maintenance. You know, let's just get right to it. But it's more complicated. Remember, there are 5 stages of this model. And you can say, well, okay, I'm going to work my way through this model and get to maintenance. But it's not that simple either. It's more complicated in that, you get here and you get here, and maybe even go back there. I mean, it is hard, especially in modern society, to be and stay physically active. So we have a lot of work yet to do to learn how to help more people achieve the physical activity guidelines and maintain them through most of their lives. So again, you go up, you fall back, and so forth. So just very quickly on a couple of these points. Again, pre-contemplation, we consider that a success in our research. If someone never even thought about being physically active, if we can get them thinking about it, that's a start. Say, well, I'm not intending to change, I'm resistant. The con's really far, I'm too busy, I don't like exercise, and so on and so forth. So there is an example. Do you get crankshaft up here in the comics? No? They get it over in Winnipeg because I asked them last week when I was giving a talk with some of these same points. But crankshaft goes to the doctor, and you see what the doctor says to him. And, okay, he's a bit of an old grouch, as you can see. So, the doctor moved crankshaft from pre-contemplation to contemplation. Good on you, Doc. And then, of course, they're in the contemplation stage, thinking about it. I'm not quite sure how I get started. I see the pros and cons kind of even. What do I do? Et cetera, et cetera. And again, I can give a 2-hour lecture on this topic, and we're going to skip through it here tonight. But what is the best exercise for each of us? Well, it's the one you will do. For some there are crazy people in this room who think kayaking is outstanding exercise. I don't know who that is, but I've heard that. Some like to walk, some run, and then there is that, what is that dopey game that you guys play up here on the ice with? Again, is that, well, I'll tell you, hockey is not good for your health if you don't do it. It might not even be too good for your health if you did do it, I suppose. We're thinking concussions and knee injuries and so forth. But it won't help you if you don't do it. So you're too busy to be physical. That's the main reason we're given. I'm just too busy. I got to get promoted. I got this paper to write. I'm too busy. But, the past several of our, I don't know about your prime ministers. I'm going to stop here in just a second. I don't know about but President Reagan was active, President Carter, President Clinton, President Bush. I mean, they've all been. Now, if the presidents of the United States can be physically active, couldn't you find a night? You're telling me you're busier than the President of the United States? And then we now have a new advocate. Just 2 weeks ago, I learned about this. Pope Francis. Editorial in the New York Times, and from what I'm not a Catholic, from what I've read in the paper, he's a little different probably than previous popes, doesn't quite live the high lifestyle as much, and he doesn't live in the, whatever they call the papal palace. He lives in kind of a Spartan guest house, and he has a little different view of the world. So according to this article in the Times, he was coming out of his guest house the other day, and there was a bishop out there who was waiting for his ride. And the Pope said, "Can't you walk?" So Pope Francis, along with the people here, Exercise is Medicine, promoting physical activity. So here's the final solution, just the last couple of slides. It's the miracle drug. And this comes from Exercise is Medicine, Abbotsford, out there in BC. I gave a lecture there a few weeks ago, public lecture, and they gave these pills to everybody who attended the lecture. Now, it's a kind of a big pill, but with a good pint, you can get it down if you really work on it. On the other hand, you can just wear it on your belt, and it will count your steps and help you monitor where you are in making progress and changing your behavior. So remember, get this miracle drug, and I'm not, okay, I will take the royalties for this, and let's get more people more active. You guys in Exercise is Medicine, keep it up here. Thank you. Are you going to try to take any questions? Or?
Yeah, so thank you very much for that compelling lecture, Dr. Blair. With that being said, we'd like to open the floor for questions. If anyone has any. So I'm just going to walk around with the microphone and just
Thanks very much for the wonderful talk. Now, if you want to be a successful varsity athlete, or in fact a successful competitive masters athlete, 75 minutes doesn't come close to cutting it. You know, you're talking about 5 or 10 times. Like my buddy over there, he cycled 75 minutes a week. He wouldn't be the world-class cyclist he is. Unfortunately, though, is there a negative effect for us who exercise 10 times as much as you're talking about, with these lousy athletes, hearts, etc.? Are we doing too much to stay competitive?
Very good question, and I quite agree. The 150 minutes a week of moderate or 75, that's not going to prepare you to be competitive, whether it's in the hockey league or just, again, if you're going out with a friend or running in a 10K race. So you have to do more. The key is training at that really high level harmful? Well, we know that for those crazy sports like football and hockey, probably there is some harm from the collisions that you have, and certainly there are musculoskeletal injuries that occur in those sports. But what about the heart? This is a very interesting question. We have a paper in review now that does show a little bit of an uptick in this population in the runners who are running, and I forget the cut points. I mean, these are not Olympic champions, but it may be. And there's been 2 or 3 or 4 other papers in the last 2 or 3 years that are suggesting maybe there is an uptick. I'm not yet convinced. I don't think we know the mechanisms. It is possible. And of course, then if there is that possibility, you can still make the choice of, well, is it worth it to you or not? But I don't think we have the science to really know. It probably is possible to do too much. You know, it's possible to do too much of almost anything. I have a psychologist friend who likes to tell of a patient in a mental hospital years ago who just wanted to commit suicide. Of course, he was in the hospital, and so he committed suicide by drinking water. Talking about that today. You can drink so much water, it throws your system so far out of kilter, you can die. So you can drink too much water, you probably can ride too far on your bike or too many miles a week or too much running. Now, let me say that is not a public health problem. It may be a problem for a few crazies. Oh, I'm sorry. Sorry.
So when we look at fitness and metrics like mortality from cancer, you showed the graphs that showed that the higher your fitness, the lower your mortality from cancer. But does fitness and physical activity affect the incidence of cancer in those populations, or are they just surviving and getting cured then because they're more fit?
No, it affects the incidence. We have really good evidence on activity and prevention of colon cancer and breast cancer. It's where we have the most evidence. But no, it's not just keeping from dying of cancer. It's not getting cancer in the first place. And then if you have cancer, there is now some pretty good evidence for breast cancer and even for strengthening exercises that exercise in breast cancer patients prevents recurrence and prevents death. So it seems to kind of function across the spectrum.
One more question, completely different though.
Give them the mic so everybody can hear.
I'm in the faculty of medicine. I've asked my students on many occasions how much teaching you get throughout medical school regarding exercise. I'm obviously it's a big part of my practice. And they always answer 0 minutes total, despite the importance of it. Now in the United States, is this the same deplorable situation where there isn't 1 second devoted in an entire medical education to exercise?
There was a paper published in the might have been the BMJ a couple of years ago on that very question in either England or maybe the whole UK, I don't remember. They surveyed all the medical schools, and in 5 years they get 4 hours. That might be something that's better than here, perhaps. So that gave me the idea. I wonder, same question you had, what's it like in the United States? So we talked to our colleagues in England who did the study, Richard Weiler and Mano Stamatakis, and they shared their methods and questionnaires. And I think we're about to get a study launched in the U.S. So you'll have to invite me back in a couple of years, and I may have some data on that. But it's not going to be a lot, I know that. Except we have a new medical school in South Carolina. And they're in second class. And so a year and a half ago, when they were starting to put this together, they hired a young woman who was, you probably met her, Bob. She was Russ's postdoc. She got her PhD in exercise physiology, University of Georgia, postdoc with Russ, did some work with me. And she was one of the first faculty members the dean hired for this medical school. And I happened to be at a reception where he was, and I said, Jerry, I'm so pleased that you hired Jen. She's going to be a really good junior faculty member. He said, I want exercise in our curriculum from day one. He's a kind of an unusual medical school dean anywhere in the world, I think. And we just had last month at this new medical school, we had a national think tank on integrating more physical activity into medical curricula. And we had representatives from, Eddie Phillips, who's keen on this from Harvard, and we had some guy representing the organization that writes the test questions if you want to get your board certification. He was there. So we had, and somebody from the American Medical Association. So I'm hoping maybe we can begin to have some impact and get a little more education on physical activity in medicals, because we have an awfully long way to go. It is pretty important. There was a paper just last week or the week before in the British Medical Journal, John Ioannidis' group, a comparative effectiveness analysis of exercise and drugs. Go read the paper. Now, the database is still relatively sparse, and John admitted that, but and he used only data from randomized trials and so on. We're getting there. Keep up the exercise as medicine. Any other questions, or everybody ready for that pint? Well, thank you for coming. Pleasure to come back to Queens as always.
So on behalf of Exercise as Medicine at Queens, we'd like to thank everyone for attending, and of course we'd like to thank Dr. Blair for taking the time out of his schedule to come and speak with us tonight.
Thank you. Thank you. Thank you.